Good morning to you all who've been able to join in so far. Welcome to yet another meeting, one of our fetal medicine meetings. Today, Dr. Verenga is going to be sharing with us on the electronic fetal monitoring. Dr. Verenga, are you ready to start now?
Yes, Dr. Tasha, I am ready.
Okay, thank you. You may go ahead. Thank you.
Good morning, colleagues, and good morning. Let me start by saying thank you so much for taking time to attend. One of the most important component of fetal surveillance is electronic fetal monitoring. I think most of you are now aware that whenever we are mentioning surveillance tools, we've always said that we are not doing CTGs because we don't have them. But now, thanks to some generous people, both of our hospitals, now we have got CTGs. And we have started training staff in the relevant units. And fetal medicine staff is also part of that relevant unit because we will be using CTGs according to the protocols that you are going to receive. Probably this is part one of a part two series. That means there is a part two series. Part one would probably describe electronic fetal monitoring in general. Then the part two will be more of its application in the fetal medicine unit to say how are we going to be using the electronic fetal monitoring in the fetal medicine unit for high-risk women that we see there. I think if you could, Dr. Tasha, if you could quickly admit the people who are coming in, because so the traditional methods that we have all come to know or come to experience is the intermittent auscultation with conduction palpation. This we've been doing for years, and it's still happening. Of course, it's not happening the right way, as you will see. Then we have the CTG, cardiotocography, is what we want to introduce. Other methods which we are yet to introduce or which are yet to happen in our shows, whether private or public, is the STEN, ST segment analysis. This is more computerized CTG. Then we also have fetal scalp blood sampling and also umbilical cord blood sampling. We are not introducing these modalities yet, but what we're introducing is number two, cardiotocography. To just refresh you really on what you have been doing to see whether it has been happening correctly or not. According to FIGO, if you decide that you are going to be monitoring the women in labor using the intermittent methods, then this is how you should do it. You should listen for fetal heart rate for at least 60 seconds. For 3 conductions, the fetal heart rate is not always in normal range. That is between 110 and 160. Then the timing, it should be during and at least 60 to 30 seconds after a contraction. Then the interval, every 15 minutes in the active phase of the first stage of labor and every 5 minutes in the second stage of labor. So this is how it should be done. This is how it should be done when you are doing intermittent. You all agree with me that this is not what is happening. What is happening is something else. People are not doing it this way, described here. Then contractions should be done before and during fetal heart rate auscultation in order to detect at least 2 contractions. Fetal movements should be evaluated at the same time as uterine contractions and maternal heart rate at the time of fetal heart rate auscultation. So you can see for yourself that we are very far from this kind of practice, which we think is the one that we are doing. So this is what we have to register, presence or absence of accelerations or decelerations. And you agree with me that none of us if you go to our labor ward, you are going to see that none of us or our charts record accelerations or decelerations. Nobody does these things, to be honest with you. Of course, this is the correct way to do it. Probably this explains why we have a lot of FSBs and MSBs in our labor ward. The frequency of contraction is in every 10 minutes. And of course, the fetal movement should be recorded if present or absent. Then, of course, the maternal indices should also be done. So that's the correct way of doing it. Then in terms of, this I've already told you, then in terms of what will be considered abnormal, if we just use the intermittent, what is it that we can detect as abnormal? We can pick that the baseline heart is abnormal, either it's below 110 or above 160, using the method that is currently being used in our units. Then as for the decelerations, the presence of either repetitive or prolonged, either 3-minute deceleration, but no one using the intermittent methods we are using is able to do this. Probably with Doppler, if people are to use a handheld Doppler, probably this will improve. But again, even when the handheld Doppler is being used, none of this stuff is being done. Then the contractions, more than 5 contractions in a 10-minute period should be recorded as abnormal, as tachysystole. Right. So I've not seen tachysystole being recorded. All I've seen are probably tonic contractions where people are saying they are too much. But it's not common to see them be recorded, but they do okay. Probably here and there they are recorded. So all I'm saying is that the auscultation, the intermittent auscultation, where we are monitoring fetus, it still needs to be improved on so that it aligns to what is known to work than what we are currently doing. There are so many shortcuts, so many, you know, we are doing things that we are not proud of sharing with the colleagues who are doing it properly. But I want to introduce the CTG. Now that the CTGs are there, what is a CTG machine? A CTG machine is an electrical gadget that records both the baby's heart rate and also the uterine activity. So it does assess the following parameters. It assesses the integrity of the fetal autonomic nervous system by when we check the baseline fetal heart rate and variability. We are assessing the baby's autonomic nervous system, the ability of the baby to respond to stressful situations. Then when you are checking for accelerations, you are assessing the integrity of the somatic nervous system. Automatic fetal movements are the ones that stimulate the accelerations. We can also assess the sleep activity cycle of the fetus if we are doing continuous monitoring. Then we can also predict the presence of mechanical or hypoxic stress. So this is how it looks. Of course, hours which we have are different from this one, but an CTG is going to have a screen that will display the values, an LCD screen that will display the values. Is going to have what you call the tachometer, which will have sort of a dimple in the center. This is what picks the change in the tension or the pressure. So that's the tachometer. Then the cardiometers are these probes which are plain on their surface. They come in tools to allow for twins monitoring. So there will come 2 of them. Then we do have the fetal, the maternal probe for fetal heart, for fetal movements. Every time the woman feels the fetal movement, she needs to press the probe so that it could be highlighted on the CTG. We also have on the machines that that both hospitals have. You'll see that there is a maternal blood pressure monitor and there is also a pulse oximeter to monitor. But this is part of will affect the interpretation of the CTG. and also a woman who is tachycardia, who are later possibility of woman having pyrexia or something like that, which will all have an effect on how we interpret the CTG. Of course, then we have the printing paper, the CTG paper printing there, where the parameters will be printed. So the role of the CTG is to monitor high-risk pregnancies. What is the role? Why are we doing fetal monitoring? Why are people doing Dopplers? Why are people making all this effort which they are making to try and monitor babies? The whole role is that people are trying to predict hypoxia, fetal hypoxia. So that's the whole role, to try and pick up fetuses which are at risk of hypoxia. So we should never lose this fact that the whole idea is to pick babies who are hypoxic, because hypoxia is what causes brain damage, that causes us to produce babies who will perform poorly in the society. I think during my time, there was a class called special class. We always used to laugh at people in special class and blame them like, you know, it was their fault. But sometimes if somebody is fried by hypoxia while inside the uterus, for sure their brains cannot be sharp enough not to be in special class. So this is the whole idea of fetal monitoring, to say no baby should be exposed to hypoxia under the watch of health care workers who are supposed to deliver a baby who is just as good as them. What is the physiology of tachography? So when we are doing the uterine muscles, we place that tachometer on the anterior abdominal over the fundus. I didn't get this correct. We place it over the fundus on the anterior abdominal wall. Then the amplitude, which we see on the CTG, relates to the change in the shape and tone of anterior abdominal wall. It does not reflect strength of the uterine contractions. So we are not directly measuring uterine contractions, but we are sort of picking up the pressure wave which is produced by the contractions, and we are picking it up from the woman's anterior abdominal muscles. So please take note of this. So it should be placed at the fundus, not anywhere else. Of course, false recordings may occur with the woman vomiting or the woman having a Valsalva maneuver from one reason or another. Then the physics of the CTG. What does the CTG do? The cardiography or the cardiometer is placed on the fetus left shoulder. The fetus left shoulder will be difficult to diagnose just by palpation, random palpation. But the good thing is we have introduced labor with ultrasound. I know we are yet to run a training, which we'll do soon. But the labor with ultrasound should help you to locate where the baby's left shoulder is. Of course, if the baby is lying on its left shoulder, that means it's putting the left shoulder at the mother's spine. Then it may be difficult, but you can as well put it on the, try to put it as close to the back as possible. And you may see that the tracing will be weaker than what it should be, because the probe will be too far away from the baby's heart. So the CTG probe uses the same principles as the one for Doppler ultrasound principles. The CTG generates electrical impulses that cause piezoelectric crystals within the probe to vibrate, the same way that happens with the ultrasound. So that means within the probe of the CTG, there are piezoelectrical crystals in there. If you just throw over or throw away the probe when you are done checking doing the CTG anyway, we are going to cause the piezoelectrical crystals to move, and the probe will not be able to work. This is a common problem. It has occurred with the machines before, because either maybe people do not have the knowledge of this, knowing that this is a gadget that can that where the its components can be displaced by dumping it forcibly, or it could be because people hate themselves so much so that they want to destroy the things that they use. But we need to have this knowledge that it is just like an ultrasound scan probe. Please don't throw it away, don't dump it, handle it with care. It's a delicate piece of instrument. So propagated waves, some is transmitted and some is reflected back when the waves hit fetal cardiac chambers, causing a Doppler shift. So this is how the tracing is generated. So waves are generated due to the vibration of the piezoelectric crystals within the cardiometer probe. And with this, the waves are sent, sound waves are sent. As the heart muscle moves, some of the waves will be back and go back to the probe, and they'll be converted by the machine into the tracing that we see on the machine. So it is these reflected echoes that also give us that audible sound, and that will represent the beat that will be traced by the machine. Always be aware that you can erroneously record maternal iliac vessels with the CTG, and you may think the baby is fetal bradycardia. I think this have done, sorry. Where am I going back? Okay, now. So the pitfalls, when performing CTG is, one of them is you may fail to put patient identifiers. This will result in the doubling of fetal heart rate or a CTG error, or you may, not necessarily to say failure to put, but doubling the fetal heart rate could be due to a CTG error, especially the setting, or halving of it could be due to the setting. Then maternal heart rate monitoring, which I've already mentioned that you could possibly put on the iliac vessels when the woman is in advanced labor. And you may also lose conduct, or we have poor signals, or there may be interference tense, and also incorrect placement of thermosensitive paper. Then the other thing that we need to understand is the fetal physiological response to hypoxic stress. So the fetus normally has a greater response than in adults due to the fetal hemoglobin, which has a higher affinity for O2. Normally the HB is between 18 to 22 grams per deciliter for the fetus. And the hemoglobin, fetal hemoglobin, has a buffering ability for both metabolic and respiratory acidosis. So they increase the cardiac output by increasing heart rate more than they do the stroke volume, which differs slightly from the adults. And the baby also preferentially shuns blood to the brain, heart, and also adrenal gland. This is why we check the middle cerebral artery, because that is what we'll be checking for. The placenta performs functions of kidneys, liver, and also the lung and the lungs. I think we should be aware of this. This is the difference between how the baby will respond to hypoxia compared to adults. Adults can increase their respiratory rate and the depth of respiration, but the baby will not be able to do that because it's not the one which is doing all these kind of functions. So as a result, the fetus is not able to maintain myocardial energy balance by increasing rate and depth of breathing in utero, and it slows down the heart rate to conserve the energy. This improves the solid filling and coronary circulation. So in other words, you are saying adults normally will respond to hypoxia by breathing too much, but babies will do the opposite because they want to conserve energy, because they are not able to breathe too much. As a result, they try to lower down the rate at which the heart is beating. So that is the whole theory of bradycardia, or the decelerations or the lowering of the fetal heart that we see when you are monitoring babies with hypoxia. Decelerations, there are different types of classification of deceleration, but people, I'm going to discuss the traditional that has been used for so many years. Then I'll just briefly share with you again the newer sort of classification that people are arguing that probably is more relevant than the old a way of saying just early, late, and so forth. So the baroreceptor deceleration, it is acknowledged that deceleration may occur because the umbilical artery is occluded. Whenever the umbilical artery is occluded, there is a rise in fetal systemic blood pressure. This rise in systemic blood pressure will cause a rapid fall in the heart rate without any delay and a rapid recovery to the baseline. So if we sorry, I'm not a good drawing. Right. So we are saying we are having a fetal heart rate which is going this way. They need to rapidly fall and rapidly rise and continue again, rapidly fall and rapidly rise. This is the kind of deceleration that is caused by fetal heart called umbilical artery occlusion due to cord compression. Normally, because the torque will be here, these are the uterine muscles. Normally, what happens with the cord, umbilical cord compression, that it has no relationship to contractions whatsoever. It is what we call variable deceleration. So if there is no relationship with the contractions when it comes to baroreceptor deceleration. Then the chemoreceptor deceleration, this is normally caused by utero placental insufficiency or repeated and sustained uterine contractions or prolonged umbilical cord compression, leading to carbon dioxide metabolic acid accumulation. As a result, this kind of deceleration will appear like this. Normally, it does appear as a late kind of deceleration. Late means it occurs after contraction. These are uterine contractions, which I'm drawing there. Then this deceleration would be doing this. Then we have probably, I'm not doing it properly here. Yeah, more like a trough. Then it comes back again. Then the heart rate continues. Then it goes again like this. So it's more open, the deceleration, because the heart gradually, there is a slow recovery of the heart rate. So this is a late deceleration kind of a picture that we see when you are doing, when there is chemoreceptor, or when you are dealing with chemoreceptor deceleration due to fetal hypoxia and acidosis. Prolonged deceleration is normally seen in cases where there is placenta abruption, umbilical cord prolapse, uterine rupture, or uterine hyperstimulation or hypotension secondary to epidural. So what we will see is that it may have no relationship with contraction, but these are contractions here. Then we're going to see the baby's heart rate, which was like this. Then we have this deceleration that stays and then comes back to normal, and it's more than 3 minutes here. This deceleration, it should be more than 3 minutes. So that is a late deceleration, prolonged deceleration that we see with this kind of condition. So if you come across a late deceleration, always think of this condition, that what could be going on. CTG should always be done with the context of the clinical picture. This is why an ultrasound scan is very important for anyone who is about to have a CTG. An ultrasound scan should have been done to make sure that the baby is growing appropriately. There's no fetal growth restriction. If it is there, it has to be noted. Then the amniotic fluid, you want to know the quantity. You want to know whether oligohydramnios, polyhydramnios, and you also want to know the staining, whether it is meconium stain. As well, for those women in labor, you want to know about the meconium staining. Then the intrapartum bleeding, chorioamnitis, rate of labor progression, and presence of uterine scar, medication which has been given to the mother or fetus, and fetal cardiac malformation, and uterine hyperstimulation, and fetal reserve. All this should be known. The clinical picture in which you are interpreting the CTG is very, very important, as you will see when I discuss some specific conditions. The uterine activity Normally, I've already told you that we are not really measuring uterine contraction per se, but we are measuring the changes that are caused by uterine contractions on the anterior woman's anterior abdominal wall. So it's an indirect assessment of the uterine contractions. And whenever we are interpreting them, we look at the frequency, the duration, and the strength of uterine contraction over a 10-minute period. This would just illustrate, this is probably a case of tachysystole. If we count the 10 minutes here, 1, 2, 3, 4, 5, almost 6. So this is more from probably tachysystole there. Probably here it's fine, it's 4 contractions in almost 10 minutes. And these are the contractions. So when you are looking at them, we count the number to say 1, 2, 3, 4, 5. Then you also want to see the strength. The strength is represented by the millimeters here, millimeters of mercury. This is the pressure of the contractions, that they are strong enough or not. We know we categorize uterine. We are saying at baseline, the torque should just be at 20. 20 is about the baseline. Then 20 to 40 is mild, 40 to 60 is moderate. Then above 60 is too strong a contraction. It's very strong a contraction. Then they should not exceed 5. If they are 6 and are beyond, that's now a tachysystole. Tachysystole means many contractions. I'm not going to talk about this. Probably we will evolve to this level at some point, but I will skip this slide. I don't think it's relevant. So whenever we are interpreting a CTG, just a second. I will reshare the slide. I think one of my slides, which I want to put here, is lost. Let me just add it here. Then I can continue. Right. So that's the slide I want to add there. Right. So whenever we are interpreting the CTG, there is a mnemonic which we are supposed to use, which will help us not to forget the steps that we need to take when you are interpreting a CTG. So there's a mnemonic called Dr. C. Bravado. So that's a Dr. C. Bravado. So it's written like this, Dr. C. Bravado. That's the mnemonic. This should be more of like this. Then A here, that's the A. Then the Bravado. Right. So it should be Dr. C. Bravado. I'll just go through each of these. So the doctor you should determine the risk. So you want to determine the risks involved, the risk of the patient. What are the possible risks that we know? These are the antenatal risks that may make us want to do a CTG. You can see from the abnormal fetal Dopplers, antepartum hemorrhage, all of these are antenatal. These are intrapartum risks. I'm not going to go through them because of time, but you can check this again on our YouTube channel to familiarize yourself with them, and also in the protocol, which will come out soon. So these are the risks of the pregnancy, which should be documented. Say these are the risk factors or the risks that have made us to put the woman on CTG. Not every woman needs a CTG. Some women can still be monitored intermittently the way that we have been doing, but that way has to be improved to align to the recommended way. But those are the risks. When we check the contractions, you want to know about the contractions. I've already shown you the contractions out there interpreted. So first of all, you want to check, are there any contractions? If there are contractions, you want to know the frequency, the strength of those contractions. Are the contractions acceptable or not? Do you have a hyper contractility, or do you have tachysystole? Those are the questions that you want to answer. Then we have the baseline rate. So that's the baseline rate. The baseline rate was saying what is the average rate at which the baby's heartbeat is beating. So for that, the baseline rate should be determined over 5 to 10 minutes. period, normally you look for a strip where there is no acceleration or deceleration. I'll describe what these are. Then the normal baseline rate should be between 110 and 160, not 120. Please take note of this. Some old people are reading old books, and those two say 120. It's 110 and 160. That's the normal range of the baby's heart rate. Bradycardia is below 110, tachycardia is above 160. So the mean of the heart rate is assessed over a 2-minute period. Let me just show you here. So we are having the heart rate tracing there. Of course, we've seen that there are some contractions, mild to moderate contractions here in this tracing. So we look for a segment that is probably 2 minutes. Then after we have identified it, we draw a line between the peaks and the troughs. The peaks are the upward, the troughs are these downwards. So we just draw a line on them in between like this, right? So that gives us about 130 here. So 130 will be the heartbeat in this case. So 130 beats per minute will be the baby's heart rate, the baseline heart rate. So you can see that the segment which I chose, there are no acceleration there and there are no decelerations. I'll show you what acceleration and decelerations are. So the next thing we want to look at the bravado. So bravado should be R there, bra. Then the next one should be V. The V, then we are saying variability. The baby's heart doesn't beat at a constant rate all the time. So it's always changing. Because it's always changing, is what you call baseline variability, which where is it? Where did it hide? Sorry. Okay. Oh, it ended up here. Right. So what is it? It is the fluctuation in the fetal heart rate of more than 2 cycles per minute. There's no distinction is made between short-term variability and long-term variability. When we are doing CTG, short-term variability is interpreted when we are doing computerized CTG. So the grades of fluctuation are based on the amplitude range. When there's absent variability, there is no detectable amplitude range. So this is the normal range between 5 to 25 beats per minute. Then increase is greater than 25, reduce it 3 to 5, absent is less than 3. What is it? So when you are looking at variability, we are looking at what is the peak here, what is the trough, and also the baseline that we have drawn. So we're saying how much, by how many beats is it changing from the baseline, going up or going down? So if we draw this line continuous, probably 140, this line is probably 135. On this baby, probably there is not much good variability. So it's almost about 5 beats. So these are the 5 beats we are looking at here. So this is how much it is oscillating around the baseline. So that's baseline fetal heart rate variability. So this is an assessment of the baby's autonomic nervous system that tells us that, look, the baby's autonomic nervous system is working. If it is no longer working, then there will be no baseline variability. It will be more of a flat trace. This is not a good trace we see there. Right, so I think we are done with the V. Let's go back to the, so if we go to the A means accelerations. Accelerations are increase in the fetal heart rate. I have accelerations here, should have. Accelerations, these are increase in the fetal heart rate of more than 15 beats or more than 15 seconds. So let me see on my charts here if I have acceleration. Let's deceleration early. Sorry. Deceleration, I have acceleration. I may not. Right. I think there's one which I saw accelerations. Let's see. Probably let's take this one here. If we assume that this is the baseline heart rate here, so this increase, which is happening here, first of all, we are saying if forget that this is an abnormal one. It's a fetal bradycardia, just to illustrate the point. So if we assume that this is 100, where the baseline is, and we measure here, which will give us something like 130. So this will be 130 there. So 130 minus 100, that will give us 30 beats. Then the duration, that means from here to somewhere, probably here, this duration should be more than 15 seconds for us to say this is an acceleration. So this is how we calculate an acceleration. An acceleration, like we said, is an assessment of the baby's somatic system, because normally the baby does what we all do, that if we increase our activity, our fetal heart rate goes up. So if the baby moves its muscles, then the fetal heart rate should go up. That is normal reaction of the baby who is doing well. So that is acceleration. Then decelerations. Decelerations, how do we know that or see the decelerations? I think one of them has it here. So for the decelerations, what you are seeing is a drop in the heart rate. So let's assume this heart rate baseline was here. We can see that there is no fetal bradycardia there. It becomes fetal bradycardia if it persists for more than 2 minutes. That means the baseline rate has been set. But if we assume that this probably somehow went up again and started, doing like this, right? So if we look here, it was almost 130, 135, 135 there, right? But there is a drop now in the heart rate to almost 90. So 135 minus 90, that gives us almost 45 beats, a fall of 45 beats. So the duration here is more than 15 seconds. This drop, which is okay to the heart rate. So this is a deceleration, which we see there. However, decelerations are classified. I've already told you that there are 2 types of deceleration, 3 types: the baroreceptor, the chemoreceptor, and also the prolonged one. But you can still classify them in the old way or the usual way that people used to classify them, which I think I should show you. So decelerations, we can classify them into early decelerations. Early deceleration, that means it starts with a contraction and ends with a contraction, so that if we draw the trough, it almost corresponds to the peak of this. Probably this one may not qualify as a deceleration. This one is a deceleration there. So what causes this? The early deceleration is normally caused by fetal head compression. So when the fetal head is compressed, that causes deceleration. Early deceleration is fairly innocent in the fact that it doesn't harm the baby. It is just a physiological response to fetal head compression. So we are going to see this in women who are in the second stage of labor quite often. Then we have the late deceleration. What is this late deceleration? If we were to draw a line straight here, we can see that this kind of deceleration more or less occurs after a contraction. Yeah, it will start after a contraction, more or less after a contraction. What causes this kind of deceleration? This deceleration is caused by uteroplacenta insufficiency. We are going to see this kind of late deceleration because of the preeclampsia we have, which causes placenta insufficiency. So we are going to see this in babies who are hypoxic from uteroplacenta insufficiency, that they are going to have this kind of late deceleration, which occur after a contraction. These are pathological. If you see this, then there's close monitoring required and appropriate action will need to be taken. If delivery is very far and the woman is less than 6 centimeters, then for sure I need to plan to deliver other methods. But if the woman is fully dilated and you think you can expedite delivery, then expedite delivery so that you reduce the duration of fetal hypoxia. Then the variable deceleration, they have a poor relationship with contraction. There is no specific defined relationship with contraction, as you can see there. The variable deceleration are caused by umbilical cord compression. So that this kind of deceleration, normally they respond to positional changes. It is common for the baby to compress the cord during the laboring process, depending on the position. So if you do see this kind of deceleration, you might need to move the woman to a position that allows the cord to be dislodged from the compression. If I go back, probably let me run it down the bradycardias and the tachycardias. So this is how fetal bradycardia will look like. So if you draw a line to see what is the baseline heart rate is, we've already done this, but you can see that the baseline heart rate is almost 100 there, which is corresponds to fetal bradycardia. Bradycardia is not always caused by hypoxic distress or fetal hypoxia. There are other causes that should always be investigated by the health practitioner. You should always check the woman's temperature to see if there's no maternal hypothermia. You should also check for congenital fetal heart block. Women who have lupus with positive anti-Ro and anti-La antibodies are susceptible to have fetal heart block. Of course, these women should, if they were evaluated in the fetal medicine unit, this will be picked. But we know that we see women who have never been scanned who come in labor in our institutions. So be alert and know that there are other causes of fetal bradycardia, such as fetal heart block. This does okay. I think we have 2 patients like this in the fetal medicine, but these ones had heterotaxy, which is a congenital heart defect, heterotaxy with left isomerism. These ones do okay. They do okay quite often. Then women who are on beta blocker therapy will also experience fetal bradycardia. So fetal bradycardia, don't just jump to say it's because there is fetal distress. More so in the antenatal period, if you are doing an antepartum CTG and you pick fetal bradycardia, then the woman will need a thorough evaluation, including assessment in the fetal medicine unit. So that babies don't deliver, they are not delivered too early. We have cases, we have followed up with fetal bradycardia due to other causes, not just hypoxia. Fetal tachycardia, we already say that a heart rate which is above 160, you are going to see it, and when you draw a line, my line may not be aligning properly, but you can see that it's 180 it is. That's the baseline heart rate here. Yeah, almost 180. So this is fetal tachycardia. Fetal tachycardia, this again to show you the fetal tachycardia, but it's discrete variability there. Then this is another fetal tachycardia due to tachyarrhythmias. You can see how the baseline is behaving there. This is for a baby with a VSD with an abnormal heart structure. Again, with fetal tachycardia, most of our antenatal, the most commonest cause of fetal tachycardia is not fetal, but maternal. So we should always think of maternal conditions such as maternal pyrexia. Make sure the woman doesn't have a temperature, and also rule out conditions like maternal hyperthyroidism, because maternal hyperthyroidism also causes fetal tachycardia. Then rule out intrauterine infection. I will show you some of the features that could make you suspect intrauterine infection on the CTG. Then, of course, we have fetal distress as one of the causes. Then fetal tachyarrhythmias. Babies, just like adults, they also have supraventricular tachycardias. They have sinus tachycardias. They have ventricular tachycardia, arterial flutter, arterial fibrillation. All these also occur in babies. Arrhythmias occur in fetuses as well. Please take note of this, especially with tachycardia. The most common cause of fetal tachycardia is not necessarily fetal distress. Then beta agonist drugs, salbutamol, we will be using this drug for sure with CTG. And always be aware that when you give it, make sure you mark on the CTG the time you have given it so that your interpretation of the CTG will make sense. Then other drugs are these ones, you don't routinely use these. Then parasympathetic blockers, atropine, we may use this in women with organophosphate poisoning. So we should be aware of this. Then, yeah, I think I've done the tachycardias. I'm sorry for putting back, but then, of course, we want the overall output, the overall impression of the CTG, which we have to make after doing all this assessment. I think I've covered all the common CTG abnormalities. There is another one called the sinusoidal pattern. Probably let me illustrate that one. People will come across it and wonder, what is it? Let me go back to my right. So sometimes you may see the sinusoidal pattern. The sinusoidal pattern is this kind of tracing that will be almost like this. It is smooth tracing. It's called the sinusoidal pattern. It is a feature of severe fetal anemia. Severe fetal anemia. When delivery is not imminent, then these babies will need to be offered cesarean. We are going to see fetal anemia in conditions such as fetal maternal hemorrhage, which may occur from unknown causes. We may also see those women who are isoimmunized. This is not common in our setting. We have not come across a woman who is isoimmunized to date. But we may see this in babies with TAPes as well, twin anemia, polycythemia, CPNZ. This may, you may see this kind of tracing. So that's sinusoidal pattern. Then in terms of variable deceleration, what we call simple and complicated. Complicated is when they go beyond 60 beats per minute and more than 60 seconds. Those are complicated variable deceleration. Right. So let's just go to the overimpression. These are the kind of overimpression that you may come across. But before we go there, what do we consider to be a normal antenatal CTG tracing? It should have a normal baseline. Variability should be between 5 and 25. There should be absent decelerations or early decelerations. I've already told you that early decelerations are not harmful. Then the acceleration should be at least 2 within 20 minutes of tracing. Then they should, for the intrapartum, for the woman who are in labor, again, the same things apply. But when it comes to acceleration, they don't necessarily have to be there. If they are absent, it's not a calamity if you don't see acceleration for women who is in labor. So this is how you then come up with the impressions. Overall impression, a normal is everything that we have said with no decelerations, and you don't have to do anything. If there's one non-reassuring feature, then conservative measures need to be taken. But if there are two non-reassuring or one abnormal feature, abnormal is persistent bradycardia is abnormal. Fetal scalp or sinusoidal pattern is abnormal. Then fetal scalp sampling or delivery of the baby has to be done. But we are not going to be doing this. So in this case, we are saying the baby should be delivered with the quickest method. If the baby is woman is fully dilated and the baby is at the right level, you can do a quick vacuum. But if not, then you offer a cesarean. Probably, let me stop here. Next week, I'm going to start at this level, where we want to talk about how we classify the hypoxias and the further action, and also how we will be implementing the CTG into the fetal medicine unit surveillance protocols. So I think I'll end here for today, since it's a two-part series. So we'll start from classification of hypoxia. Thank you. Thank you, Dr. Lachayo.
Thank you, Dr. Verenga, for that highly informative talk. We can't wait for the next session next week. I'm not sure if there's anyone with questions so far concerning the CTG. If there are, please, you can either unmute and then ask your question, or you can write something in the chat box, the question that you have. Thank you.
Sorry, Dr. Verenga, thank you for your presentation. I don't know if I missed it. I came in a few minutes late, but I just wanted to ask about the use of CTG and on, like, they call it an admission CTG. Will that be carrying, is that of any use in patients who are coming in just routinely doing an admission CTG where there is no risk assigned to a patient?
Thank you so much for that question. I think the clinical utility of CTG involves high-risk pregnant women with high-risk pregnancies. So for women with low risk, I do not think there is proven benefit to offer every woman a CTG before we admit them. But for high-risk women, probably it is good clinical practice point to be certain of the fetal status before the patient is admitted, if they are high-risk women with some of the risk factors that we have highlighted there. But one thing that will limit us, of course, we are trying to draft a protocol, a guidance on where to use the CTG. Was one thing that will limit us is we don't have 20 CTGs. Our 2 hospitals are high volume centers. As a result, we have to carefully select our patients so that 1, we can cope, 2, we can offer the women we think will really benefit from the being done as CTG, and also so that the staff can cope. So I do not see us being able to do an admission CTG for now, but we have to even further stratify our high-risk group into a very narrowed group so that it is workable for the moment, because we have 3 CTGs for each of the hospitals, and 1 would definitely be required in labor ward, and probably another one in labor ward, in early labor ward, and maybe another one in antenatal ward. Already they are not enough. So things like that will make it impossible to do that.
Thank you very much. And I also wanted, because I thought it would be necessary to inform people that not every patient needs a CTG. And also I wanted to ask about mobilization of patients. For example, you put a patient on CTG. We know that these are women who are already at risk of DVT. How long should we put a CTG on a woman? For example, if a woman has got a fetal distress and it corrects, and after monitoring for CTG, you notice that it's correct, it's now okay, or it remains abnormal, how long should we keep them immobilized because they're on CTG?
Which CTG are you referring to, Doc? Are you referring to antenatal or intrapartum?
No, intrapartum.
Intrapartum. The intrapartum CTG, the ideal thing is for babies who have high risk. Ideally for intrapartum, the whole goal is to monitor the woman continuously. And for women who are high risk, that would be the perfect thing to do. But for us, we are going to face a challenge whereby we do not have enough CTGs. So we may still find ourselves doing intermittent CTG monitoring for our high-risk women, so that all the women who think their babies have to be monitored with the CTG to be certain in terms of decision making can get the benefit. So we might not be able to put a woman on a continuous CTG. But coming to your question of mobilization, most women, while mobilization is something which is generally encouraged and advocated for women in labor, but high-risk women, they will benefit more from having their baby monitored rather than them moving around. The women who are really high risk, people with abnormal Dopplers, fetal growth restriction babies, or people who are having antepartum hemorrhage, they will benefit more from having their babies monitored than them mobilizing. And besides, our labor wards are not mobilizing labor wards. I don't know of the colleagues who are here in this platform, how many women have you seen mobilizing in our corridors while in labor? Most of them, they are actually lying on their bed. So in our situation, I do not see this being a big problem, to be honest. Maybe in other countries where mobilization is part of routine and women there's aggressive encouragement of mobilization. But in our setup, most women are comfortable lying on their bed in labor. I don't know if your experience is different, but this is my experience in doing labor ward rounds.
No, I do agree with you. Most of our women are not ambulatory, but it's just a risk factor that I thought may affect. But yeah, you are right. Most of our patients do not mobilize.
May I also add on something onto that? I think the purpose of monitoring the baby with an abnormal CTG, with the high risk, is to discover if there is a problem and then do an intervention. So I don't think you will continue monitoring forever that fetus. If there's an abnormality, then obviously you need to do an intervention. And in our case, we can't do fetal scalp sampling as yet. So the obvious thing, as Dr. Verenga had said, is to do an emergency section or emergency delivery if the patient is about to deliver. So I don't think you'll monitor for loss and for a very long time, because the risk of DVT also will be there if you do monitor for hours and hours on end. Thank you.
I think my last question is on CTG. I think I remember reading somewhere that it increases the risk of cesarean. I appreciate the use of a CTG, but just to critique that, does it not increase the risk of getting a cesarean section done without necessarily improving perinatal mortality rates?
I think your question is valid, but from the talks that from the research work done by Zako Firevic, who has done a lot of systemic reviews, it has been shown that there could be some benefits if we put a high risk woman on CTG. We acknowledge that yes, it has a very poor sensitivity, but the specificity is very good. In our case, where we are delivering FSB and MSBs, where our baseline is very high here. Baseline in terms of neonatal outcome, the bed neonatal outcome, we have a very high baseline, which is different from countries with a very low baseline. So if CTG is to be tested in countries with a very low baseline, the changes are going to be very tiny because everything else is being done properly. But in our case where MSBs and FSBs, actually FSBs are being mislabeled as MSBs because there's just too much death of babies. Personally, I think we are going to get some benefit in monitoring these women. One of the reasons why we are doing these trainings, Doc, is this training is not by any means over, and this is not the first, neither is the next week will be the last, is to train, because CTG needs extensive training of users, so that users do not panic and intervene unnecessarily, especially with cesarean section. So we're going to be doing intensive training until doctors and our midwives are very confident when they are interpreting the CTG, so that there is no panic, and everybody should realize that the sensitivity is not good, but the specificity is amazing for the CTG. If the CTG tells you that the baby is healthy, it's highly unlikely that the baby is healthy. The problem is if it tells you that the baby is not well, it's highly likely that the baby is well. Both sensitivity is around 20 to 30% there.
Yes.
So extensive training is the answer. We have to do extensive training of ourselves, and we also have to do CTG meetings where we review these CTG meetings. But I have no doubt that in our situation where our baseline rates, our baseline for neonatal, for MSBs and FSBs is so high, CTG will certainly make impact if everybody put their hands on the deck.
Thank you very much.
Any other questions? Please go ahead and ask if anyone else has a question. So far, there's nothing in the chat box. Okay, if there are no further questions, then I think we can close the meeting. It's now after 9. So if there are no further questions, we can close the meeting. Dr. Verenga,
Okay.
do you have any other comments that you'd like to make before we close the meeting?
Thank you so much for attending. Next week, we will continue the CTG talk. I think next week, maybe Dr. Ziki and went up ahead of time, but next week we'll be addressing the issues like the ones Dr. Ziki was asking, and we will be also discussing the evidence surrounding the CTGs. Probably we will. It will be more at a higher level next week. And I hope my colleague from London will also be able to join us for that meeting, for the next week's meeting. So yeah, so see you next week. Bye-bye.
Thank you, Dr. Verenga. Thank you all for attending. Bye.